day, my dear menopausal students. I'm so glad to see you here in class again today. It would have been a huge mistake to miss this video tutorial. And the reason it would have been a huge mistake is that this video is all about PCOS management mistakes. This is video number 460, and it's the last video in our little unit on polycystic ovary syndrome, or PCOS. The whole unit consists of just 6 videos. In the previous 5 videos, I've schooled you on the definition of PCOS in video 455, the 3 hormonal abnormalities of PCOS in video 456, the diagnosis of PCOS in video 457, treatment of PCOS in video 458, and the effect of menopause on your menopause in video 459. In those videos, I touched on some of the PCOS management mistakes that are quite common. But because they are so common, I thought it best to make a separate video on nothing but PCOS management mistakes. So that's what I'll do here today. As I've warned you in the previous PCOS videos, none of this is in my book. So please watch this series of PCOS videos here on YouTube for your education on PCOS. Okie dokie, let's get started. You've learned that PCOS is a disease that manifests itself over your entire reproductive life. It's not just an isolated entity that affects your periods. You've also learned that despite the name polycystic ovary syndrome, it is a disease of 3 different organ systems: dermatologic, reproductive, and metabolic. Instead of PCOS being the acronym for polycystic ovary syndrome, its name should be permanent cardiometabolic ovary syndrome. And that's because PCOS is really diabetes of your ovaries, and it causes all the same long-term problems that you see with diabetes type 2. Well, because of its inaccurate name, doctors and patients make a variety of common mistakes in management of PCOS, and I want to bring them all to your attention. For purposes of organization, I think it's best to address these PCOS management mistakes in categories. They tend to fall into 3 categories, which are location, timing, and depth. So I'll present them in terms of how they fall into those 3 categories. The first category, location, pertains to the fact that due to its inappropriate name, most people assume that PCOS is merely a disease of your ovaries. But it isn't. Instead of being localized to your ovaries, it is a total body disease that ultimately affects multiple organ systems. So instead of being a local disease, it's a global disease. The second category, timing, pertains to the fact that PCOS is not limited to your reproductive life. It is not a short-term temporary disease. It's a long-term permanent disease. It affects you through pre, peri, and post-menopause. The third category, depth, pertains to the fact that PCOS does not entail only the manifestations you can see externally or superficially. It also affects many bodily functions that are internal or deep. So we're going to refer to our 3 categories as local versus global, temporary versus permanent, and superficial versus deep. See this Lego building I've made? Notice that it has a crooked roof. But take a closer look. Notice that it's not only the roof that is crooked. The foundation is cracked too. And it is this cracked foundation that is making the roof crooked. If you fix only the roof, the building will still be defective and probably crumble, simply because the real problem is the cracked foundation. Likewise, if you treat only the local, temporary, and superficial aspects of PCOS, you will crumble simply because you have not treated the PCOS. So I'll use this cracked foundation and crooked roof building to help you understand these PCOS management mistakes that fall into the categories of location, timing, and depth. I'll go through the timeline of how PCOS plays out over the course of your lifetime using the same format and chart that we've used throughout this unit. And I'll point out the PCOS management mistakes in each of these 3 categories. So here's our familiar chart that you've seen a bunch of times now, as long as you've watched these videos in order. Focus on the first row in pink. It's the row designating how PCOS manifests at the time of puberty. The typical symptoms of PCOS during puberty are hirsutism, acne, and irregular, unpredictable, infrequent, or absent periods. We'll address the hair and skin symptoms here in the puberty phase. We'll save the menstrual symptoms for the reproductive phase. Obviously, hair and skin symptoms seem like local symptoms, but they are actually global symptoms. And they are not due to anything having to do with your hair or skin directly. Your hair and skin are just the targets of the underlying problem, and they are not the cause of the problem. The hirsutism and acne are due to high testosterone, and the testosterone is not coming from your hair follicles or your skin. It's coming from your ovaries. So it's a global rather than a local problem. And while these symptoms become apparent for the first time at puberty, they are not temporary like they are for women who do not have PCOS. With PCOS, these symptoms are permanent. Likewise, they are not superficial problems. Your hair and skin problems are merely reflections of deeper abnormalities. So everything that results from PCOS at the time of puberty is global, permanent, and deep. The PCOS management mistakes during puberty include everything that amounts to managing these symptoms as if they're local, temporary, or superficial. So if you only use antibiotics, Retin-A, skin drying medications, Vanica cream, electrolysis, laser, Rogaine, vitamins and minerals, infrared light, or hair transplant for your hirsutism and acne, rather than an anti-androgen, you will be making a very big mistake. So, when it comes to the PCOS symptoms of puberty, hirsutism and acne are the crooked roof. But if you only fix the crooked roof, you are going to fail in solving the very thing that makes it crooked. The only successful way to fix the roof permanently is to fix the cracked foundation. And anti-androgens are the proper PCOS management for hair and skin symptoms at puberty. And complete treatment of PCOS starting at puberty requires even more than that, because there's a lot more to PCOS than just hair and skin. So let's go on to the reproductive phase. That's where we'll discuss the abnormalities in your periods. Here's our chart. Focus on the blue row. With PCOS, as soon as you start having periods, you notice that your periods do not occur on a regular or predictable schedule. Instead, they're irregular, unpredictable, infrequent, or even absent altogether. And the reason your periods are never normal is anything but local, temporary, or superficial. All of your period problems are due to high luteinizing hormone, or LH. But it doesn't come from any of your reproductive organs. It comes from your brain. So once again, it's a global problem rather than a local problem. You learned a long time ago that LH is one of your brain hormones that runs the whole show of menstrual cycles and ovulation. And if the hormone that is running the whole show is wonky, it wreaks havoc with everything that follows. So, as a result of too much LH from your brain, your progesterone stays persistently low. You never fully mature or ovulate a single egg. And your endometrial lining always stays thick. None of this is local, temporary, or superficial. It's all global, permanent, and deep. The biggest PCOS management mistake for abnormal periods is to completely ignore your abnormal periods. This just enables the disease to spiral out of control. Doing nothing to regulate your periods is like letting both the crooked roof and the cracked foundation remain. Eventually, the entire building will crumble. The second biggest PCOS management mistake for abnormal periods is to use a progestogen-only option. Remember, low progesterone is a consequence of high LH. Fixing just the low progesterone will not correct the underlying problem. You simply cannot correct a hormonal problem in your brain by treating a different hormonal problem in your ovaries. Taking progestogen only for your irregular, unpredictable, infrequent, or absent periods is like fixing the roof and leaving the foundation cracked. It amounts to ignoring the real problem that caused the crooked roof in the first place. And this is probably the most common mistake of all. The only adequate and efficient way to treat all the nuances of your abnormal periods is to start taking estrogen plus progestogen birth control early in your reproductive life and stay on it at all times, unless you are trying to actively get pregnant. Somehow women have the idea that estrogen plus progestogen birth control is unnatural. I think they hear that nonsense from their ignorant girlfriends. Well, I'll tell you what's a lot more unnatural. PCOS. Estrogen plus progestin monophasic continuous birth control is the most important part of managing the reproductive aspects of PCOS. If you don't take them, you are managing them as if they're local, temporary, superficial, rather than global, permanent, and deep. You will completely miss the boat on treating your PCOS. And you need to take estrogen plus progestogen birth control in addition to anti-androgens for your high testosterone. Omitting either one is a huge mistake. The third most common PCOS management mistake is failure to notice that the metabolic abnormalities begin in your early reproductive life. Now, they aren't as obvious as your wonky periods, but they are ultimately more significant. This means that in order to adequately treat the reproductive aspects of PCOS, you have to also treat the metabolic abnormalities. The metabolic abnormalities are not local, temporary, or superficial. They are global, permanent, and deep. Treating the metabolic abnormalities is the same no matter where you are in your reproductive life, premenopausal, perimenopausal, or postmenopausal. It requires all of the following: an insulin sensitizer, a statin drug, weight loss if you're overweight or obese, diet, and exercise. The most fatal PCOS management mistake of all is failing to manage the metabolic abnormalities early in life. Unfortunately, this is also the most common PCOS management mistake. Because the name polycystic ovary syndrome has the word ovary in its name, both doctors and patients tend to ignore the underlying metabolic abnormalities. Failure to treat them early has the most severe and disastrous effects later on. And that's because everything about metabolic abnormalities is always global, permanent, and deep. Failing to manage your metabolic abnormalities is like letting both the crooked roof and the cracked foundation remain. Eventually, the entire building will crumble. So if you want to completely treat PCOS in your reproductive years, you will need to continue taking an anti-androgen, take an estrogen plus progestin monophasic continuous birth control, and treat the metabolic syndrome. This is the only way to manage PCOS as global, permanent, and deep, rather than local, temporary, and superficial. Our next phase is pregnancy, or attempts at pregnancy. Most women with PCOS who try to get pregnant discover that they have infertility issues. Be aware that PCOS is one of the leading causes of infertility. If you experience infertility when you try to get pregnant, you could have PCOS. But PCOS and infertility are two very different things. If PCOS is the cause of your infertility, you need to treat the PCOS. But if you overlook the PCOS and just seek infertility treatment, you are handling it as if it's local, temporary, and superficial. But it's not. You aren't infertile for reasons that are limited to your reproductive anatomy. You're infertile because of the high luteinizing hormone production by your brain. That's the underlying cause. And no infertility treatment targets that underlying cause. So if you treat only the infertility and not the PCOS, it's a big, big mistake. If your infertility is really due to PCOS, treatments that are only for infertility rather than PCOS will be like fixing only the roof and ignoring the cracked foundation. And what happens if you do manage to get pregnant? Well, this is typically where all thoughts of PCOS are thrown out altogether. Nobody tends to think about much of anything other than pregnancy during pregnancy. So while achieving pregnancy may seem like success, it does nothing to benefit your PCOS. And you still have PCOS after you deliver. The other thing to know is that PCOS causes complications of pregnancy. The two most common complications are gestational diabetes and gestational hypertension. Now, these two complications of pregnancy can occur for many reasons. Ideally, obstetricians would entertain the possibility of PCOS in every pregnant woman who has them. But unfortunately, they don't. Instead, they just manage them as complications of pregnancy, ignoring all consideration of PCOS as the underlying cause. Instead of managing them as global, permanent, and deep, they manage them as if they are local, temporary, and superficial. So, failure to recognize PCOS as the cause of pregnancy complications is like fixing the roof and leaving the foundation cracked. Well, at some point, you start transitioning from your reproductive life to your perimenopausal life. Now, don't make the mistake of assuming that you can't get pregnant during perimenopause. In fact, for women with PCOS, pregnancy may actually be easier to achieve than it ever was before perimenopause. This is because perimenopause usually makes periods more frequent and more regular for women with PCOS. So one big mistake is to assume that you're still infertile. Well, I can't demonstrate that with my cockeyed building, can I? But another common occurrence at perimenopause is abnormal uterine bleeding. Not only are your periods much more regular, they are also much heavier. A big mistake is to treat the abnormal uterine bleeding as single episodes that are local, temporary, and superficial. They are not. They are global, permanent, and deep. That heavy bleeding is a result of your long-term long-term, excessively thick endometrial lining. All too often, women with perimenopausal abnormal uterine bleeding will get treatments that do not target the PCOS at all. Instead, they just treat the bleeding as bleeding. These include progestogen all by itself, dilatation and curettage, commonly known as DNC, endometrial uterine ablation, or total hysterectomy without bilateral salpingo-oophorectomy. None of these will address the underlying problem. So often, a woman will have a total hysterectomy, but keep her diseased polycystic ovaries. Horror upon horrors! That's just plain goofy. Anything short of total hysterectomy with bilateral salpingo-oophorectomy for abnormal uterine bleeding constitutes fixing the crooked roof while ignoring the cracked foundation. If you want to completely treat the abnormal uterine bleeding of PCOS at perimenopause, you will need to continue taking an anti-androgen, have a total hysterectomy, bilateral salpingo-oophorectomy, and treat the metabolic syndrome. You need to remove your uterus, your cervix, your fallopian tubes, and your ovaries, not just some of them. Finally, we get to postmenopause. Now, this is where you may make the mistake of thinking that you are now unaffected by your PCOS. Maybe you think you've outgrown it. Well, that is not true. At postmenopause, there is nothing about PCOS that is local, temporary, or superficial. Everything about it is still global, permanent, and deep. Sure, you stop having periods, but that does not change the fact that your brain still produces too much luteinizing hormone. The only consolation is that your brain produces too much follicle-stimulating hormone, too. If you still have your ovaries, they are still polycystic. But all ovarian cysts at postmenopause are cancer until proven otherwise. That's the prevailing mantra because postmenopausal ovaries are supposed to be dead. Dead, dead, dead. They should be so shriveled and tiny that your doctor cannot feel them on pelvic exam or see them on ultrasound. But polycystic ovaries do not look dead. They are still large, and they still contain cysts. So how in the world are you going to know if something else develops with all those cysts? Confusing the picture. So keeping enlarged polycystic ovaries at postmenopause is a huge mistake. The other big elephant in the room at postmenopause is the metabolic syndrome. It's the most life-threatening aspect of all with PCOS, and yet it gets ignored the most. In some ways, even though postmenopause may seem like a time when you leave your PCOS issues behind, the truth is that they are really just revving up. Things will get worse, not better. They just won't fall into the category of reproduction. So the biggest mistake of all at postmenopause is failing to recognize metabolic syndrome as being due to PCOS. As such, you still have to treat the other aspects of PCOS that contribute to your metabolic syndrome. So complete management of PCOS at postmenopause entails continuing to take the anti-androgen, getting rid of your uterus, cervix, fallopian tubes, and polycystic ovaries by having a total hysterectomy, bilateral salpingo-oophorectomy, and treating your metabolic abnormalities. Notice that you cannot completely treat your PCOS by keeping either your uterus or your ovaries. Keeping either would constitute failure to see the cracked foundation. The cracked foundation of PCOS is a high risk of both endometrial uterine cancer and ovarian cancer. That's why keeping either your uterus or your ovaries is a huge, huge management mistake. Do you see why it's so important to manage PCOS as a disease that is global, permanent, and deep, rather than one that is local, temporary, and superficial? No matter how or when you address it, management of PCOS requires targeting all three organ systems and all three hormonal abnormalities. Anything short of that is a huge management mistake. So, your summary is that there are many PCOS management mistakes. They include treating only the hirsutism and acne at puberty, ignoring your irregular, unpredictable, infrequent periods, using progestogen only rather than estrogen plus progestin monophasic continuous birth control, failing to start treatment of the metabolic abnormalities in your early reproductive life, treating infertility without treating the PCOS, managing pregnancy complications while ignoring the PCOS, treating abnormal uterine bleeding at perimenopause as just bleeding rather than as PCOS, and failing to treat metabolic syndrome at postmenopause as a consequence of PCOS. At every stage of your life, you must treat the actual underlying PCOS. This includes an anti-androgen, an estrogen plus progestin monophasic continuous birth control at all times unless you are actively trying to get pregnant, management of pregnancy complications as a result of PCOS, a total hysterectomy, bilateral salpingo oophorectomy if you have any surgery, and lifelong treatment of metabolic syndrome. And that does it for PCOS. Now you see why I thought it necessary to present an entire unit on it. Please be sure to schedule a consultation with me at menopausetailored.me. Do it even if you don't have PCOS. Subscribe to my channel and my newsletter even if you don't have PCOS. And follow me on social media even if you don't have PCOS. Bye, my dears.